we're gonna talk about adolescent development, pubertal development, and Tanner staging. So I'm guessing I point this one. There we go. Okay, so our objectives here to understand Tanner staging, recognize how it's used in evaluating pubertal disorders, distinguishing between normal and abnormal pubertal development, recognizing signs and symptoms of precocious puberty and delayed puberty, and understand normal stages of adolescent psychologic and cognitive development, which Dr. Rome was just touching on a little bit, and then understand the important concepts of adolescent medicine. So pubertal development is this transition from sexual immaturity to maturity and getting your body ready for fertility in the future, and you get these secondary sexual characteristics that develop. And in this development, you get decreasing sensitivity of the hypothalamic pituitary gonadal axis and increasing your pulsatile release of GnRH, LH, and FSH. So first question, what is the first sign of pubertal development in girls? This should be an easy one. So let's see. Yeah, good job. So breast budding. And there can be some variations in the onset, timing, tempo, and magnitude of pubertal changes that you see, but those can all be normal. With this variability, the progression through puberty is predictable. So that should be the same, meaning the order in which things go in should be the same, but the ages might change a little bit, might be a little earlier, might be a little later for people, and it might happen a little faster or slower for people, but the order that the steps happen should always be the same. So what is the first sign of pubertal development in boys? Yeah, good job. Testicular growth is correct. Did that show? There we go. Okay. So normal puberty. The mean age of onset is about 11 years old in girls and 11 and a half in boys. Girls' breast development is the first sign of the onset of puberty, and boys, you see an increase in testicular size. You'll see the volume will get greater than 4 cc's, and the length becomes longer than 2.5 centimeters. In progression from a Tanner stage 2 through 5, so going through all of puberty, takes anywhere between 2 to 4 years. Next question, what is the typical chronologic progression of pubertal changes in girls? Good. There you go. You guys have got it. And then our next question, what is the typical chronologic progression of pubertal changes in boys? Yep, a little more discrepancy there, but we'll talk about this. So here's our, I know it's a kind of a lot to look at, but a slide from Tanner, hence your Tanner staging, for maturity in girls and going through your pubertal stages. So you can see around 11, it starts, let's see if I can do this. So around 11, you start having puberty, and then you can see pubic hair development, how that varies throughout. Your breast budding starts at Tanner stage 2 there. Your girls, the biggest thing to differentiate from the boys is peak height velocity is here in the middle around age 12. And then comes menarche. So menarche is the last part of puberty for girls. And the peak height velocity is there, usually between Tanner stages 3 and 4. So you want to remember that difference for girls. Boys, on the other hand, so you can see, again, starting around 11 and a half, 12, they start testicular development. You can see the variations in pubic hair development there. And then penis and testes enlargement and length, you can see that. But again, peak height velocity is going to be on average about 2 years later in boys than in girls. And so that's why guys tend to be a little bit shorter than girls before they finally get to high school and they get these big growth spurts and they get their peak height velocity. So that's good to remember for boys. That's pretty much their end point in puberty. Oh, there we go. So premature telarchy is early breast development. These are, normal pubertal variants that we're going to talk about next. You have premature telarchy, where you get early breast development without any other signs of puberty. So usually you can see this before the age of 2 or after age 6. And you're not going to see hair development, body odor, those types of things. If you see that, that's in a kind of thinking in a different category. But these are normal variants that you may expect when you see patients in these age ranges. Premature adenarche, again, early development of pubic hair, usually occurs between ages 6 and 8. And you have to kind of be careful too with different ethnicities. Oftentimes families will become a little distressed because they see hair down there. Sometimes it's just kind of your normal ethnic hair patterns, and some of them look a little darker, but you're really worried about those coarse type of hairs if you start to see those types of hairs. Again, no height acceleration or advancement in bone age would you expect to see with either of these variations. Again, letting you know that this is a normal pubertal variant and not something that you would necessarily need to be concerned about. And you just continue to reevaluate every 4 to 6 months and make sure that they're progressing in the normal developmental fashion. Just a picture of breast budding there. And again, this is going through Tanner staging and breast development. So I think it's probably easier to somewhat see on the picture. So Tanner stage 1, obviously, no breast development. 2 is when you get budding. 3 is a little more budding, but the areola and papilla are still flat. 4 is your mound on mound. So the areola and the papilla stand out on top of the breast. So you get like little double mound. And then 5 is your adult breast development. And then we'll go through male. It's easier, I think, on another picture. And then we'll also go through the hair patterns. But for boys, again, the 4 cc's is pre-pubertal volume. So once you start going greater than that, they are into pubertal development, and we'll go through those stages here. So SMR1, no pubertal development, small 4 cc's testes. Then testes enlarge, and you start to get some penile length, and you can follow that all the way along till you get to SMR5. What's easier to note here in this picture, no hair, SMR1, SMR2, you have very sparse, fine, downy hairs, kind of scattered. SMR3, a little more coarse and more hair. 4, you're starting to make this adult triangle here, but it's not actually out on the thighs. And then 5, you have that more out on the thighs. And that's the same for guys and girls. So we'll talk about gynecomastia. This is transient breast development. That typically resolves within 2 years. It affects a fairly decent amount of males going through puberty. About 75% of males will experience gynecomastia. And it occurs usually between Tanner stages 2 and 3. The etiology, it may be due to estrogen, androgen imbalances, or increased tissue sensitivity that you see this occur. Pathology that you want to think about is Klinefelter syndrome. Any exposure to estrogens or drugs that would increase breast development, or any breast tumors or other hormone tumors. And treatment is usually reassurance. Most often this will resolve, as I said, within 2 years. Sometimes surgery is necessary if you have a patient that would be equivalent to a female SMR3 of breast development. That may be someone, 3 or 4, that may be someone who then needs to be evaluated with surgery and may require surgical treatment for their gynecomastia. And one thing to note, I think it comes up later, but just so I don't forget, when you're thinking about gynecomastia, and even when you're doing Tanner staging for girls, you want to also feel the breast and make sure that it's actually breast tissue, so you can actually feel that breast bud there under the nipple or areola. You want to make sure, especially in a patient that may be overweight or obese, that it's not just fat tissue, and that actually is breast tissue developing. So we'll talk about precocious puberty. That is the onset of puberty before the age of 8 in girls and age 9 in boys. There's central versus peripheral precocious puberty. Central is the reactivation of the HPG axis, which is 5 times, central precocious puberty is 5 times more common in girls. Most cases in girls are idiopathic, but if you see this in boys, you really have to think about neurologic causes. Greater than 60% of the causes in males are neurologic. So central precocious puberty in a boy usually is not idiopathic and should be worked up. And then you have your peripheral causes, which we're going to get to. So you want to differentiate central from peripheral and identify appropriately and appropriately treat the cause of precocious puberty. Here are your list of numerous things that can cause central, but as you see there, idiopathic, again, the most common in girls. If, again, central in boys, you want to make sure you're looking for some of these other things. Any other brain tumors, malformations, like septo-optic dysplasia, hydrocephalus, possible infection, trauma, and then we drop down to peripheral precocious puberty. The most often what we see and what we think about is congenital adrenal hyperplasia, particularly late onset. Ovarian cysts could be a cause of that. McCune-Albright again, one of those ones that always pops up on the board, so I know a little something about that one. Exogenous hormones, and hypothyroidism and other hormonal tumors like adrenal or gonadal tumors that could potentially be causing peripheral precocious puberty. On physical exam, you want to look at Tanner staging, obviously. Again, this is what I was mentioning before. You want to make sure there's true breast development versus if it's just actually fatty tissue. Visual inspection of the vagina to assess for estrogen stimulation. So in a prepubertal patient, the non-stimulated mucosa is that shiny, glistening red vaginal mucosa. Versus in a pubertal girl, you're going to see that pinkish color and more rugated vaginal mucosa. History is obviously really important. You want to look at their growth pattern, how they've been growing over time. And a general assessment of their health, their nutrition, what medications they may be taking. Again, a good neurologic history. Has there been any trauma, infections, headaches, visual changes? Pubertal symptoms. So when did they start to notice breast development or hair development, and what has the progression been, and what order has it been in, and what was the onset of puberty in other family members. And then again, any exposures to exogenous hormones. That's pretty much the same. Other pubertal changes like acne, body odor, axillary hair, we talked about that. Fundoscopic exam and examining or evaluating the visual fields is important, particularly if you are concerned about central precocious puberty. Looking for any pigmented lesions like you may see with neurofibromatosis or McCune-Albright syndrome. Again, neurologic assessment. So to just touch on one of the more common ones that we evaluate for and look for in terms of peripheral precocious puberty is congenital adrenal hyperplasia. So especially for females looking for ambiguous genitalia, is there virilization of the clitoris? Males, is there incomplete masculinization? And is there advanced somatic development? You would be evaluating this in someone that you would see with precocious puberty, what that development has been, and looking at short stature. This is diagnosed with clinical and laboratory findings. And I think it comes up later, but we'll talk a little bit more about what we see in that. But which of the following children has precocious puberty? Good job. So the 8-year-old overweight boy with fatty breast tissue, again, fatty breast tissue, not breast development, not true breast development or gynecomastia necessarily. The 12-year-old girl who has regular menses, that's normal timing. 12-year-old boy with enlarged testes, again, that's what you would expect. The most common cause of precocious puberty in girls is woohoo! Good job. Idiopathic. So we'll talk a little bit more about laboratories and imaging studies. Bone age you can look at you would expect it to be advanced with precocious puberty. In children with premature telarchy or premature adenarchy, you would not see an advanced bone age. So again, this could be a great tool to determine if this is a normal variant or actual precocious puberty. Your gonadotropins, Usually random levels aren't very helpful, and they may not be elevated. So in most cases, unless you're really worried about a central process, we don't usually get those. But we can do a GnRH stim test for children that you're trying to differentiate central precocious puberty from peripheral. Children with central will have a brisk rise in the LH and FSH, whereas in prepubertal children or those with peripheral precocious puberty, they don't show a rise in the LH and FSH because your axis is shut off. And then you can check estradiol and testosterone levels to see if those would be in pubertal ranges. Again, looking for other causes, checking your thyroid studies, DHEAS for possible adrenal tumors, and 17-hydroxyprogesterone to check for possible late onset congenital adrenal hyperplasia. Pelvic ultrasound might be helpful to identify any large ovarian cysts or neoplasms if that's maybe a concern of what is causing the precocious puberty, and also to assess the development of the uterus and the ovaries. And a high-resolution head MRI is recommended for girls younger than 5 and any male who you're concerned about central precocious puberty should get a head MRI. Imaging of the adrenals and gonads, again, depending on what you think may be the cause of the precocious puberty, that might be helpful. So for therapy, with regards to central precocious puberty, GnRH agonists can be helpful. Those bind to and stimulate the receptors, and that continuous stimulation is what then turns off your gonadotrope signals and secretion of LH and FSH, and essentially puts you in a halting pattern. This is also the same thing that you would use basically in people that you're pausing puberty to potentially think about transitioning with gender. And tumors, central nervous system tumors, resection, chemotherapy, radiation may be indicated. Hypothalamic hamartomas can also be treated with a GnRH agonist. Adrenal and gonad tumors, usually resection is the treatment there. CAH, you want to replace their glucocorticoid. Hypothyroidism, thyroid treatment, thyroid replacement treatment, obviously. Large ovarian cysts may require resection depending on how large they are. McCune-Albright syndrome, some things you can do, ketoconazole, testolactone, and spironolactone can help with some of the precocious puberty signs that you're seeing. So now we're going to talk about delayed puberty. And this is the lack of secondary sexual characteristics by age 14 for boys or by age 13 for girls. So this means no development by those ages. And they're typically smaller than their peers. Short stature is exaggerated by lack of their growth spurt. This is typically more common in boys than girls. And you do want to think about your patients that have not progressed through the stages of puberty within 4.5 to 5 years after onset. You wonder what may be causing that delay. And then also this can have a lot of psychological and social implications for the patient, so you want to make sure you're evaluating and managing those as well. It's not really fun to not be in the same place as your peers, so it's important to manage that as well. Some of the differential diagnoses that you can see for delayed puberty, of the more common ones, constitutional growth delay and Turner syndrome are probably more common, but hypopituitarism can be a potential cause. Chronic illness or malnutrition, hypothyroidism again, hyperprolactinemia, gonadal failure that you would see with Turner syndrome or Klinefelter syndrome, and then some other disorders, but those are usually the more common ones. So for evaluation, again, history is always key. Delayed puberty, you can ask about in either parent. Is there family history in one or both parents? Any trauma or medical injury that might have caused these delays. Eating disorders are a big red flag when you see delayed puberty in girls and boys, but a lot of times you see it in girls. And their nutritional status. Anosmia can be a sign of what? Kallmann syndrome, perfect. So that might be something that also, again, is causing delayed puberty. And then rigorous physical training. So your female athlete triad, people that are Olympic athletes may have delayed signs of puberty. And then again, physical exam, looking for any dysmorphic features that might trigger you thinking about Turner's or Klinefelter's, and then looking at body measurements, particularly height and weight, to assess nutritional status and any growth delays. So again, a bone age is very helpful. Onset of puberty correlates better with the bone age than with your chronologic age. Gonadotropins can be helpful. Random LH and FSH levels are helpful only if they're elevated. So if they're low, it's kind of hard to tell what that means. TSH, T4, again, to rule out hypothyroidism, prolactin to rule out hyperprolactinemias, and CNS imaging for any intracranial pathology that you might be thinking about. Karyotype can definitely be helpful if you are concerned about Turner syndrome or Klinefelter syndrome. So one of the more common things that we see is constitutional growth delay. This is short stature in childhood. It's a low or normal low growth velocity. You usually will see a delayed bone age in respect to their chronologic age. And again, there's usually a family history of one or both parents also having delayed growth. Final height, they usually reach their expected final adult height. It just may take a little while. So the most common cause of delayed puberty in boys is great. So we went through that. Reassurance and potentially a short course of hormonal treatment may be necessary, but typically just reassurance. Again, if you think about your normal pubertal growth development for guys, the growth spurt is going to be later. This may be even later for some guys, and so reassurance is usually all that's needed. So a 13-year-old girl is referred for evaluation of short stature and delayed puberty. Her past medical history is significant for a congenital heart defect repaired as an infant, and the following feature is commonly associated with her condition. Which one of those would you pick? Good. So what are we talking about here? Turner syndrome, perfect. 1 in 5,000 live born females may be affected with Turner syndrome. It's actually really interesting. I've not had that many Turner syndrome patients in my 2 years that I've been with the clinic. I have 2 mosaic Turner's patients that both have had children. So your karyotype that you're looking at is 45 XO. Again, there are mosaics. Clinical findings, you usually see skeletal growth disturbances, short stature, cardiovascular anomalies that you have to be aware of, lymphatic obstruction, renal and renal vascular anomalies, again, gonadal failure, and other various findings there. But those are the big ones to kind of pick out and remember. Therapy. You want to treat the underlying medical disorders appropriately, again, looking globally at delayed puberty. And replacement with gonadal steroids at the normal age of onset, particularly for Turner syndrome, is appropriate. For constitutional growth delay, again, reassurance and follow-up. They may, again, need a low dose of hormone therapy, but usually I do that in conjunction with endocrine. So a 14-year-old boy is brought in for evaluation of short stature. He's at the 5th percentile for height. He has early Tanner stage 2 pubic hair and 2 cc testes. Further evaluation is most likely to reveal Great. So just to point out, he's 14, short stature. He's at the 5th percentile for his height and weight. So 5th percentile for height and weight are pretty much the same, which again can maybe clue you into, is there something else going on if maybe his weight was down but his height was normal or higher percentile. And has early Tanner stage 2 pubic hair, so he's not, he does have some development. He's not without any development at this stage, so that's good. So yes, you would expect a delayed bone age and likely constitutional growth delay. What finding would you expect in central precocious puberty? Wonderful. So right, in central precocious puberty, you have now turned that HPG axis on. So you're going to see more of your, you would expect to have elevated LH and FSH in response to that. Which one of these statements is true about adolescent growth? So D, a little more differentiation there in choices. So your average, if you look here, average prepubertal height velocity is about 5 to 6 centimeters a year, so a little less than what was stated there. Peak height velocity, again, if you remember, I said that usually occurs about 2 years after girls. So for boys, they're usually about 2 years later than girls. And then pubertal growth accounts for about 17 to 18% of your final adult height. And then your average growth velocity in puberty is about 9 to 10 centimeters a year. So to talk a little bit about weight and body composition growth, onset of peak weight velocity is really variable. Pubertal weight gain accounts for about 50% of your ideal body weight. Your lean body mass percentage increases for males and decreases for females. And 33 to 66% of your adult bone mass accrues in adolescence. So this is why, if anybody is prescribing Depo and talking with their patients about going on Depo, this is why people get concerned about when and how long you're on Depo-Provera. Erythrocyte mass increases in males and is more level in females, and blood pressure rises related to age, weight, and height. So case 1, 15-year-old slender boy presents with delayed puberty, a heart rate of 42, orthostasis by pulse. What is the most likely diagnosis to explain all of these findings? Okay. So your answer is C. So he is delayed puberty, heart rate's bradycardic, he's orthostatic. All of that put together, I would probably go with an eating disorder. Usually in a well-conditioned athlete, while you may see a low heart rate, typically low 40s is not where we would like to see you, and usually not where they are. We do get concerned if you're walking around with a heart rate of 42. Usually your heart rate drops about 10 beats per minute overnight, so that puts you in the 30s overnight, is typically when we admit you to the hospital for an eating disorder, possibly. Which of these statements about adolescent psychological development is false? So E is the correct answer. Parental approval of an adolescent's separation from the family enables the adolescent to psychologically return to the family later. True. The peer group is important for adolescent parental separation. I mean, peer groups in general are important to adolescents in this time period. The peer group has a powerful influence on the adolescent's healthy and unhealthy behaviors. True. And pubertal maturation requires role readjustments between family members, also very true. Adolescents do not consider parental views and values on sex when deciding about their own sexual activity, when in fact they do actually consider and hear what their parents are saying. They don't always listen. It's that frontal cortex, that brain, that part of the brain, and the impulsivity that is a bigger drive sometimes, but they do actually hear it, and at some point in life will consider those things and go back to that when looking at their own views. Oh, there we go. A 15-year-old girl who has had menarche at age 13 presents with a chief complaint of 4 months of amenorrhea. 1 month before loss of menses, she started a health kick, which increased fruits and veggies in 20 minutes, with increased fruits and veggies, and was doing 20 minutes of exercise daily. She's lost only 3 pounds. She has also noticed orange-tinged skin in the last month. What is the most likely cause of her amenorrhea? Okay. So C it is. Oops, sorry, I was going to go back. Menarche at age 13, she's 15. Typically, we would expect about 2 years after the onset of breast development, so breast budding, that she would have her periods. And it doesn't say when she got her, menarche at age 13, sorry. So 2 years after you would expect that her periods would be regular. She's on a health kick, which always gives you a clue. 20 minutes of exercise, but she's only lost 3 pounds, and she's had 4 months of amenorrhea. So, which one of these statements about adolescent cognitive development is false? All right. So D it is. Concrete thinking characterizes the early adolescent. That is true. Experience and environment can substantially influence cognitive development. True. Early adolescents do not easily link cause and effect in regard to health behavior. Very true, if you go back to A, concrete thinking. And then the late adolescent is not capable of abstract reasoning. So if you think about adolescence, what you're doing basically cognitively is moving from concrete thinking to abstract reasoning. So the late adolescent should be capable of abstract reasoning. And the adolescent's concept of immortality influences risk-taking behavior, which is very true, which is why we talk about a lot of high-risk behaviors in counseling with adolescents. Again, that impulsivity issue is with adolescents. So case number 3, a 15-year-old girl is admitted to the hospital with severe anorexia nervosa. She weighs 35 kilos and is 160 centimeters tall. She has bradycardia and orthostatic hypotension. You plan to stabilize her medically and begin refeeding. Of the following, the electrolyte abnormality that is most likely to occur during the first week of her treatment is... Wow, good job. So you can see other electrolytes lower, but hypophosphatemia is the one that you're going to be worried about. The other big one we worry about is your potassium being low, but hypophosphatemia is the big one. And that is your adolescent medicine review.